Good morning. We are going to start content talking about the heart, reading rhythm strips, and what's abnormal and what we're going to do about it when we do see something abnormal. At this point, you should have already gone through Ms. Doeg's content on hemodynamics. You also should have reviewed Ms. Curley's PowerPoint on anatomy of the heart and blood flow of the heart. You should have watched a con video that was on the module about the anatomy and blood flow of the heart. You also should have completed any required readings prior to watching this video. If you've not done so, you need to start with that. If you do not have a good grasp on the anatomy of the heart and the way the blood flows through the heart and the pathways, you are not going to be able to understand this information very easily. So you need to make sure you have a good, solid base and understanding of anatomy. I'm not going to go over that at this time. You have other resources for that. So let's go ahead and get started. Quickly, briefly, as I just said, you need to be familiar with the cardiac assessment and blood flow of the heart. We're just going to do a quick overview. Make sure you understand what is involved in a cardiac assessment, where you would listen to different heart sounds, what those heart sounds represent. You need to understand perfusion related assessment findings. What things do you assess to see if perfusion is happening? So things like pulses, edema, the color of the patient's skin, level of consciousness. These are things you need to be thinking about. Remember, we're going to talk more when we get into the abnormal things with the electrical system of your heart. What we're constantly going to be talking about is, what does that mean to blood flow? What does that mean to perfusion? What does that mean to your patient when these things are happening? So you need to understand all of those things that you've built on since semester 1 in Nursing 111 or in 215 for you guys that were in there, that when we talked about perfusion-related assessment findings, decreased pulses, pallor, decreased capillary refill, changes in level of consciousness, these are all things you need to be aware of. Make sure you are aware of the different components of the heart and the anatomy of the heart, where it's located, where is blood pumping, where does that pathway take the blood, which valves are involved, where are they at in the heart, as well as the coronary arteries. You'll get more information on valves in Unit 2. For now, we're going to talk about electrical conduction. And last thing, just reiterating, the blood flow and understanding how the blood flows to the heart is going to be imperative to being able to understand what's happening when you're reading an EKG. So remembering where the pathway of the blood, what carries blood to the body, what carries blood to the lungs, what's happening during systole, what's happening during diastole. This is all review, and I'm not going into it, and I cannot iterate enough how important it is that you understand it before you move forward with the more difficult content. Make sure you have a good grasp of the basics of the heart, the anatomy, before you go into the rest of this content. I think I have hopefully driven that point home. So if you are still with me, I'm going to assume that you do have a good grasp on cardiac anatomy and how to assess perfusion and where to listen for heart sounds and all that good stuff. So let's go ahead and look at this electrical system of the heart. In addition to those mechanical parts, the chambers, the valves, all that, we're going to now look at the electrical system of the heart. So this is your first, this is the first time that you've been introduced to this, since you've been in nursing school. We've talked about it. You've probably taken care of patients that were on a telemetry monitor. So now we're going to look at why did they need that, and what does that look like? How to read it. What does it mean for the patient? So the electrical pathway that you read in an EKG reflects the movement of the blood and the squeezing of the heart. So we're going to look at each piece of this individually. We are going to review that EKG in more detail coming up. So let's just talk about that electrical system of the heart first. Your heart has the most amazing ability to generate its own electrical pulse. Some of those cells in your heart have the ability to generate their own electrical pulse. That is called automaticity. So that is very special for those particular cells. They generate an electrical pulse, and then that electrical pulse travels along a pathway, and with that electrical pulse, those cells then contract along that pathway, and that leads to the contraction of those chambers of your heart. So along that pathway, let me get my pencil out. Y'all are going to find that I just love a pencil. It's one of my favorite things that I do on these things. So here we've got the SA node, or the sinoatrial node. So this has that automaticity, and it's going to fire off and then follow these pathways down which is going to lead to a contraction. Now, don't fret. We are going to talk more about the sinoatrial node and each of these pieces to the puzzle on the next slide. We're going to talk more in detail about each of these parts. On this slide, we're just going to kind of do an overview of what's happening. So we've got these cells that are creating their own electrical impulse. They're shooting it down the atria through these pathways that are leading to a contraction of those atrial chambers, the top chambers of your heart. Over here, we've got a little thing called Bachmann's bundle, which just kind of collects and disperses electricity, because this SA node is at the top of the right atrium. It's at the right atrium. So over here, we've got Bachmann's bundle at the top of the left atrial. So this SA node is going to shoot down all over the right atrium and then send across to Bachmann's bundle that's going to spread it around in the left atrium. Okay, next up, I'm going to change colors. I think I'm going to go with yellow, because there's already, it's already yellow over there. There's already a lot I'm going to go with green, because there's already some red and yellow over here. So then we're going to come down to here. We've got the atrioventricular node. Atrioventricular. It's between the atrium and the ventricles. So that is why it's called the atrioventricular node, right in the middle. So these electrical pathways are going to go from the SA node, drop it on down to the AV node, and from the AV node, they are going to travel up into around the ventricles to lead to that ventricular contraction that's going to give us all the blood flow to our body. From our right ventricle, we're going to go up and into the lungs to get oxygenated. Then from the left ventricle, we're going to go out the aorta and into the rest of the body. So these pathways are super important. Without that electrical impulse, you're not going to have a contraction. So if you do not have these electrical impulses, or if you've got a break in the circuit somewhere, you're not going to get contractions. You're not going to get perfusion to the rest of your body. So that is why this is all so, so important. As it comes down here in this lower pathway, excuse me, it is going to, that blood flow is going to come down through this left bundle branch and a right bundle branch. So they're going to kind of branch off to the right and to the left into the ventricles. Okay, so now that we've looked at an overview, let's look at each piece of this electrical pathway in a little bit more detail. And remember, the glorious thing, I'll say this a couple more times, so just get used to it. The glorious thing about these recorded sessions versus a live session is that you can pause me and rewind me anytime, and you can read at the bottom what I'm saying. And hopefully it's correct, but it should be. But you can always rewind, pause, go back over something. This information in this unit, just like in, from 111 on, we've kind of stacked on top of, it's going to be the same way with this content. This is going to be the base of this Unit 1 information for perfusion. Actually, the base was the hemodynamics by Ms. Stoic, and then now this, and the other two presentations are going to build on top of that. So you need to have a good understanding of this before you move into the next. So just pause, go back, review, to make sure you're understanding. Okay, so your SA node. Electricity is going to follow these pathways, and it is going to start in your normal heart. With this first presentation, we're going to talk about normal. So with a normal electrical pathway, let me get my pencil back, handy dandy pencil. In a normal electrical pathway, it's going to start right up here at the top of your right atrium in this SA node. Your SA node is your primary pacemaker for the heart. Every normal beat, every single normal beat that your heart produces starts right here in the SA node. This is where normal begins. Understanding normal is going to really help you understanding abnormal. So make sure you understand what normal is. So normal beat's going to start in the SA node at the top of the heart. Primary pacemaker. So as your primary pacemaker, its normal inherent beat, the amount of times that it beats a minute, is your normal heart rate. So 60 to 100 beats a minute is what is built into your SA node that it is supposed to do. Your SA node is going to reflect that atrial firing, or depolarization is the term we're going to use. And I'll talk more about depolarization and repolarization when we get a little bit further along. But that depolarization is that electrical impulse is causing that contraction during depolarization. And then during repolarization, it is relaxing and going back to a normal resting state. So, SA node, primary pacemaker. If your SA node's working, your heart is beating about 60 to 100 beats a minute in a normal rate and rhythm. It's starting there and making its way down. So your AV node, right here right in the middle, between atria and ventricles, this AV node is, it kind of works to hold it. You don't want, if you had the electrical impulses shooting down pathways from your atria straight on down into your ventricles, what would happen? Both sides would get squeezed at the same time. Would that be functional at all? No, it would not. We need our blood flow to be squeeze, 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 squeeze. And that's what that electricity is doing. If this electricity went all the way down and there wasn't anything to control that, we'd have just like mass chaos happening. And it would not be good for your perfusion. So your AV node kind of collects the electricity. Let me go ahead and erase so that doesn't look confusing. Okay, and then I'm going to change colors. 2. So let me go back to my pen. Okay. Okay, so we got your AV node. So your AV node, get a better color, collects the electricity that has been fired off by your SA node. It holds the signal and controls that electrical impulse down into the lower chambers of your heart so that we don't have craziness happening. So it goes SA node down to the AV node, which kind of holds it there and collects it before shooting it off into your ventricles. Okay? So your AV node also will pick up the pace. If something happened to your SA node and it stopped working, your AV node would pick up the slack, but it doesn't beat as many times a minute just out of its own doing as your SA node does. Your AV node has an intrinsic rate of 40 to 60 times a minute. So if this SA node just stopped working all of a sudden, then your AV node would pick up and beat about 40 to 60 times a minute. So you do have a backup if this SA node fails. All right, so what happens after the SA node? We go down into this bundle of His right here. It's pronounced His, not His. I don't know the reason for that, but that is how it's pronounced. So the bundle of His here is where it goes off of your atrioventricular or AV node. That bundle of His also has automaticity, just like your AV node and your SA node, but they only follow their pathways and they won't go back upstream. So if your SA node failed and your AV node failed, your bundle here does have some automaticity, but it's only going to go to these ventricles, but at least that's better than nothing, right? So you do have a little bit of a backup. So the lower, if your SA node fails at 60 to 100, then your AV node picks up at 40 to 60. Your AV node fails, your bundle picks up, but it's going to continue to go slower down that pathway. There's going to be less control, less beats per minute. So when you get down to this bundle of His, if it's what's picking up, its intrinsic rate is only about 20 to 40 beats a minute, which again is better than nothing, but still not really good for perfusion purposes. So from this bundle of His, you will go down, you will see the electricity will go down into the right bundle branch around this right side of the heart and into the left bundle branch around the left ventricle. And they not only get these branches that are going to cause depolarization or contraction, but they've got off of them, they've got these little fibers, Purkinje fibers, going out to get maximum contraction down there in that big cardiac muscle that's contracting hard to send blood all through the lungs to get oxygenated from the right and all through the body to get oxygenated from the left. So that's those Purkinje fibers. Oh, I see that it is spelled with a U and I spelled it wrong with an E. Sorry about that. So that is going to be that conduction. Let me go ahead and erase all my colorings. All right. So next up we have a video, a con video on conduction of the heart. And it's basically, this is going to be an overview of everything that we just looked at. And so I'm going to go ahead and play that on here. You can watch it on your own time. You can just fast forward on this recording if you've already watched it.
Here's a diagram of the 4 chambers of the heart. So let's name them to get started. So we've got the right atrium up here. We've got the right ventricle down here. We've got the left atrium and the left ventricle. So these are the 4 chambers. And blood is going to flow through all of them and then get out to the body. So to do this and to do this right, the heart has got to coordinate how it squeezes. And we know that the way that it kind of squeezes down is you have a cell, and that cell is usually negatively charged, and it will at some point become more positively charged. And we call that process depolarization, right? So depolarization is the idea of going from a negative membrane potential to something much more positive. And when you depolarize is when the muscle cell can squeeze down. So where does that begin? Let's actually draw it into our diagram. So if you were to look, there's actually an area here where little cells can actually depolarize by themselves. And that's actually quite unique because most of the cells in the body are going to depolarize when that neighboring cell depolarizes. So these are actually really unique cells because they're depolarizing all by themselves. And we call that area the sinoatrial node. Sinoatrial node, sometimes called the SA node, sinoatrial node. And the fact that they can actually depolarize by themselves, we have a word for that too. We call it automaticity. Automaticity. So it just means that they can kind of automatically depolarize without having a neighbor do it first. So once they depolarize, what happens after that? Well, when these cells depolarize, they're connected through little gap junctions to the neighboring muscle cells. And so they're going to start sending out waves of depolarization in all directions. And so it's almost like going to a football game and watching the waves start. It just goes on and on and on. And so all the neighboring cells are going to start depolarizing as well. And that orange arrow is moving kind of slowly, right? That depolarization wave is moving kind of slowly relative to how fast it could be moving if it went through a specialized band of tissue. So this band of tissue that I'm drawing, this blue band, is almost like a highway compared to that orange arrow, which is like a little road. And that highway is going to take that same depolarization wave over to the other side, over to the left atrium. And all of these cells begin to do the same thing. They start depolarizing as well. So you get depolarization happening both in the right atrium and the left atrium in a coordinated way. So it's happening all very, very evenly. And this band or bundle is called Bachmann's bundle. So it's like a little bundle of tissue, right? So it's called Bachmann's bundle. So now we've named two things, the sinoatrial node and Bachmann's bundle. And actually, just like Bachmann's bundle, there are actually a few more little bands of tissue, almost like little highways, that take that signal down to another node called the atrioventricular node. So this right here is the atrioventricular node. And the atrioventricular node is really the only major connection, I shouldn't even say only major, only connection in most of us between the atria and the ventricles, the atrioventricular node. And this is actually sometimes called the AV node. So the AV node is going to get the signal, and actually I didn't even tell you what that signal came through. It came through, this is kind of a generic name, internodal, meaning between two nodes, tracts. And that's kind of the name for all three of them. So the signal went from the SA node through the internodal tracts down to the AV node. And there, kind of an interesting thing happens. So if you actually take a step back and look at the AV node, let's imagine we're now kind of focused in on exactly what's happening there. And to figure out what's happening there, I'm going to give you a little scenario. So let's say that you've got, let's say a little timeline here. And that timeline is, let's say 1, 2, 3 seconds. 3 seconds. And your job is just to watch the atria and see how they contract. So you just watch the atria and you say, wow, I saw one contraction that happened right there, and one contraction that happened right there, and one contraction that happened right there. So the atria, as they get the wave of depolarization, are contracting now 3 times in 3 seconds. So for the atria, you saw 3 contractions. Now you do the exact same thing, but you do it for the ventricles. So for the ventricles, you kind of just keep an eye and you watch, exactly what happens, and you notice that there's a contraction of the ventricles there, and again there, and one more there. So both the atria and the ventricles are both contracting the same number of times, but the unique thing is that there's like this little delay between the two, right? They're not actually contracting at the same moment in time. there's this tiny delay, and if you measured it, it would be about 0.1 seconds. So just a tiny little fraction of a second. But the reason that there's that delay is due to the AV node. So one of the kind of interesting things about the AV node is that it creates a delay between the atria and the ventricles. So delay between atria and ventricles. And the reason that that's really important is that if the atria and the ventricles were actually contracting simultaneously, then they would actually be squeezing blood against each other. They would be actually doing work that wouldn't actually move the blood in the right direction. So by creating the delay, the atria can squeeze, the blood can move from the atria to the ventricles, and then a tenth of a second later, the ventricles can squeeze, and then the ventricles can move that blood onwards. So the reason for the delay is actually to make sure the blood moves in a coordinated way through the heart. So now the signal has delayed by a tenth of a second, but then it continues on, right? It continues on, and it goes to a little area right there, and this is called the bundle of His. Bundle, kind of funny names, I know. Bundle of His. And even though it's, spelled H-I-S, you don't say his, it's hiss, almost like what a snake does. And then it continues from the bundle of His through one track down here, and this is considered the right bundle, and then it goes through the left bundle. And actually the left bundle splits. There's like a forward part that goes up to the front and a part that goes to the back, and I'm going to draw the back part kind of dashed like that. So this is called the left posterior, because posterior means back, posterior fascicle, and this is called the left anterior, because it's coming forward, anterior fascicle. And you got to kind of imagine that it's going forward and back, because obviously in 2 dimensions it's hard to show that. And then this is just called the right bundle. And actually, just so you're not ever mistaken, this part right here is called the left bundle, where it's still combined and it's not broken into the 2 fascicles. So you have the left and the right bundle, and then the left bundle splits again. And then all the fibers get really kind of split up here at the end. And these are called the Purkinje fibers. And it happens on both sides. Purkinje fibers. And from this point, basically, the electrical signal can kind of dash out in all directions, right? So you can finally get all the muscle cells involved. So up until now, it's been part of the electrical conduction system, meaning these are all the highways, but now you have all of the waves of depolarization going through all the little tiny roads. And I'm using the idea of roads and highways just to point out the idea that through the electrical conduction system, the signal moves really fast. And when you get down into the muscle itself, then the signal moves slightly slower. But you can see that that's important because that's the only way to get all of the muscle cells on the same page. So this is how the electrical signal moves from the SA node all the way through the electrical conduction system so that the atria are beating together, and then goes into the AV node where there's a little delay, and then down into the ventricles where, again, the ventricles are going to beat together.
Okay, so hopefully that video kind of helped drive that all home. I'm super jealous of the Convideo pens and their ability to draw things much better than me. So when we suspect an actual or potential alteration in those electrical pathways and that conduction system of the heart, we can use a telemetry monitor to monitor that electricity and those pathways. So what we're going to do first up is indicate need. So if we've suspected that there could be an actual or potential alteration in that electrical pathway, we've determined that we need to do some cardiac monitoring. So let's talk about that. If you are going to be applying the monitor, make sure that you have the correct size electrode. There are different electrodes for pediatric and infants than there are for adults. The skin should be clean and dry. Don't shave the hair with a razor, just use the clippers. You can use benzoin to help it stick. If somebody's really sweaty, that may help. And typically we attach the leads to the electrodes first. So the leads are the wires that will connect to the electrodes. So we've got the wires, and we'll go ahead and click those on to the stickers that we're going to attach, those electrodes we're going to attach, because sometimes they're kind of hard to do. So if you attach it to your client first, and then you're having to push that that lead, is what we call it, the lead or wire onto the patient, that can be kind of uncomfortable. So attach that first. The electrodes need to be changed daily. They have a little moisture pad in them, and they kind of get dry, and connectivity can decrease. So we need to change those electrodes daily to make sure we've got a good visual. So when you are monitoring somebody on a monitor, you may see that they're on a 3-lead monitor or a 5-lead monitor, or there's a 12-lead EKG. When we talk about the leads, they're the wires, as I said, but those leads are everywhere that they're attached to the patient. It's almost like a camera angle. They're taking pictures from a different angle. So you're going to see that electricity pathway coming in from a different direction. The more camera views you have, the more accurate the picture is, right? So a 3-lead is going to have fewer views of the heart than a 5-lead, and that's going to have fewer than a 12-lead. So we'll talk more about 12 leads coming up. But when you're monitoring, you do want to see in at least 2 leads. Typically, we monitor lead 2 because it has a good camera angle of the SA node and the atrial waves, and then also V1. So when you are in clinical and you're looking at the telemetry monitor, you can see that you can see all the views, but we always want to monitor in 2. If you're on a continuous cardiac monitor, we'll monitor in 2, and typically that's going to be lead 2 and lead 5, V1, so that we can get the best angles to observe from. So let's talk about lead placement. All right, so we've got here our patient's chest. So you have on your leads or wires, you have 5 different colors. You've got white, green, red, black, and brown. So my way I remember where to put them is white on right. So white goes on the right side. White on right. And then to know which one goes on top, it's going to be snow over grass. So white on right, snow over grass. So we got our green lead down here. When you're placing the leads, you just want to try to get them in a clean area, and try to go between the ribs. You don't want to be right over top of a bone. So white on right, snow over the grass. So that leaves the left-sided ones. So for the left side, we're going to do smoke over fire. So smoke over fire. So black goes up top, red goes down below. And then what we've got left is brown, and brown goes in the middle. So that's it. So that's how you place them. All right, with a 12-lead EKG, we've got a few more to place. Typically, those 5 leads are what you're going to see in a hospital setting at the bedside. That's what you're going to have your telemetry patients on. most CCU patients are going to be on a 5-lead monitor. Sometimes you may see your CCU patients on a 12-lead all the time. So let's look at that 12-lead. For the 12-lead, you have 4 limb leads, and then you have 4 limb leads and 6 leads that go on the chest. So for those limb leads, like LIMB, you are going to put those limb leads are going to be just there on your limbs. So one on your right arm, on your left arm, and then on your calves will be your other 2. And they are labeled right arm, left leg, right leg. So they got RA, LA, LL, LR, or left leg, right leg, RL, LL. On the wires or leads, so that you'll know which ones go there. So for the placement of the middle leads, the V leads, we say, so V1 is going to be 4th intercostal space, right sternal border. V2 is going to be, you're just going to hop across. It's going to be 4th intercostal space, left sternal border. The next one you put on, we're going to skip V3 when you're placing them. The next one you're going to put on is going to be V4. So you'll skip down to V4, which is going to be sorry, it's going to be 5th intercostal space, mid-clavicular line. So go mid-clavicular, right, and about in the middle of the clavicle, and then 5th intercostal space is where that V4 will go. You can then go back to V3 because you're going to just stick it right in the middle. You're going to stick it right between these 2. Next up, I usually do, you're going to do, sometimes I go ahead and do V6 before I do V5, but you can go ahead and do V5. It's going to stay on the same horizontal line as V4 was, so that 5th intercostal space down, but this is going to be stay same horizontally, but the anterior axillary line. So anterior axillary, like the front of the axilla, anterior axillary line, and then V6 will be right beside of that V5 lead. So that one's anterior axillary, and then V6 is going to be mid-axillary line. Same horizontal plane as V4. So that V4 placement is going to be super important. So V1, 4th intercostal space, right sternal border, then hop across the left sternal border for V2, V4, 5th intercostal space, mid-clavicular line, V3, drop right between those 2, V5, same line as V4, but anterior axillary, and then V6, same line, mid-axillary. So you may have noticed that there was only 4 stickers that we talked about, right? So there was the 4 limb leads, and then now there's 6 V leads, so or chest leads. So that's only 10, and we call it a 12-lead EKG. And that is because, remember, we talked about the views that you get. And so with those 10 leads, you get 12 views. So that is why it's called a 12-lead, not a 10-lead. All right, so now we've got the EKG in place. So what are we going to do with it? We are going to read it. So we're going to talk about learning to read the EKG. So every part of the EKG or electrocardiogram has its own name. Each little piece that you see here has its own name that we're going to be calling it. So we're going to focus on normal in this presentation. We're going to focus on reading normal because it is so important to learn normal to be able to understand abnormal. If you have a good grasp of what normal is, then you'll understand when there's something abnormal, what does that mean for your patient? Excuse me. So as we said, the EKG is going to map electrical activity in the heart. So in each EKG, I'm going to get lots of pen action. Okay, in each EKG, you'll see each of these, we'll call these complexes. In each complex, it's got the same parts to it. So these parts all have their own name. This is going to be called, oh, let me go over here. This is going to be called the P wave. This big part here is going to be the QRS complex, and we've got a T wave. So let's talk more about each of those pieces. All right. So here we've got your P wave, that QRS complex. Let's do up here, QRS complex, and your T waves over here. As we talk through these, we're going to talk about what each of these things represents in the cycle of your heart, in the squeezing of your heart. So we've got some things that are called segments and some things that are called intervals. With a segment, we're talking about where it is, where it lays in this whole complex. And with an interval, the interval is going to be the amount of time it takes for that interval to happen. And just don't hang tight. We're going to go through all these pieces. So we're going to start with looking at each of these pieces, this P wave, the PR interval, the QRS complex, and then this QT interval and T wave are going to be some of the things we're going to start with looking at. All right, so first up, we have the P wave. So each part of the EKG represents something else happening. It represents some portion of the contraction and muscle movements of your heart. So your P wave is representative of your atrial contraction. So when we see this first little bump on your EKG, that P wave is representing that electrical movement from the SA node to the AV node and that atrial contraction that comes with it. So that P wave, this beginning here, this is going to be where your SA node fires off. SA node fires off, and then that electricity is traveling through the right atrium, causing depolarization or contraction, right? So that's what we have with your P wave. That movement of the electricity through the atria causing an atrial depolarization and contraction. Next up here, we've got, let me change colors, I don't love that. Next up here, we've got your PR interval. Right here is your AV node. Well, here is where it got to your AV node. Remember, we talked about that electricity goes through that SA node at the top of the heart, down to the AV node at the septum here, and is held there to control the beats so that they're not all contracting at the same time. So that's what's represented here with this PR interval. Interval meaning the amount of time that it is taking. So this interval, this space here, represents the amount of time that it is taking for that electrical impulse to go from atrial contraction to ventricular contraction over here at QRS. So this represents the amount of time that the AV node is holding on to that electricity. So next up, we have your QRS complex. That QRS complex is the biggest. Guess what else is the biggest? The ventricular contraction. So that is what is going to be represented here with your QRS complex. You've got here at the end of your PR interval, that electricity is being released from the AV node and sent out to your ventricles via the bundle of His, and the right and left bundle branches down into the ventricles of the heart, leading to the contraction. So what we see on the EKG is the QRS complex representing that that ventricular contraction. And so from the beginning of the QRS complex to the end of the QRS complex is going to represent the amount of time that it takes for the ventricles to get through that electricity, to get through the ventricles. Last up with our T wave. Our T wave is going to represent the recovery phase or repolarization, which is those cells returning to their more relaxed state. So your T wave is representing that repolarization and the and your cells returning to the relaxed state. So that time is what we measure, which we'll go into in a minute. What we measure is your QT interval. So time-wise, the amount of time starts at the beginning of the QT and goes over to the end of the T wave. So that QT interval is going to measure how long it took for the ventricular contraction and for it to return to a relaxed state. So let's start talking about how we measure all these things. Okay, so what do we need to know to read a rhythm strip? And we are going to talk about each pieces of this puzzle. So do not fret. So first up, we need to know, are all parts of the EKG present? So as we said, every part should have a P wave, QRS complex, T wave. Every single full complex should have a P, QRS, T. So is that present? If you're looking at a strip, does every EKG complex have that P, QRS, T? Next up, we're going to measure the PR interval, QRS complex, and the QT interval and determine if those are normal. And as I said, we're going to go through all this. Next up, we're going to determine if it is a regular rhythm. And lastly, we're going to determine if the rate is within normal limits. All right, so let's talk about reading these strips some more. Each small box, so on your EKG, you've got these big red boxes, and then inside of those red boxes, you've got these little bitty boxes, right? So these little bitty boxes, each little bitty box represents 0.04 seconds. So these boxes are representing an amount of time. So when we're reading the strip, we're actually measuring how much time it is taking for electricity to travel from one part of the heart to the next. So each tiny little box is, and you are going to have to memorize these numbers. You are not going to be successful if you do not memorize these numbers. 0.04 seconds. Tiny little box. So 5 tiny little boxes equals, so 5 tiny little boxes here, let's see, represents, 5 tiny little boxes, represents 0.20 seconds. So 5 times 0.04 equals 0.20. So 5 tiny little boxes is these bigger red squares. So these bigger red squares are 0.20 seconds. Therefore, if you had 5 of these 0.2 seconds, big red squares, 5 of them This is going to be times 5. So 5 little red squares equals 0.20 times 5 big red squares equals 1 second of time. And we've got that shown out here. We've got 0.4, 0.20, and 1 second. I'm going to talk more about rate in a minute, so I'm not going to get too into this right now. All right, so let's talk about measuring each of those pieces that we talked about as far as what we need to know. The first thing that we need to measure out, that we want to measure out, is this PR interval. The PR interval goes from the very beginning of the P wave, when you first see it leave what we call this here. You see this line that's, well, it's straighter than what my pencil line is. It goes across here, here to here. We call this line where it's right at normal, where everything's flat, the isoelectric line. So when you leave the isoelectric line, that is going to begin your PR interval. So that PR interval, remember, that's representing, I would ask you, so if you don't know, I would encourage you to pause it and think for a minute. It is going to be that SA node firing off and atrial contraction. The amount of time it takes that is happening between this P wave is atrial contraction, the interval then between the P wave and the QRS complex is the amount of time that the AV node is holding on to it. So this full PR interval that we're measuring is the amount of time it takes for electricity to leave the SA node until it leaves the AB node and leads to ventricular contraction. So this represents the time needed for travel from the SA node until it is ready for ventricular contraction, leaving the AB node. All right, let me erase what I've got on here. Okay, so when we are measuring the PR interval, we're going to start, as I said, beginning of the P wave to the beginning of the QRS complex. So what we'll do, we're going to use this one. So the beginning of the P wave is just after this little line here to right, which is happening right on this line here. So what we're going to do is we're going to count the little boxes. So here we've got 1, 2, 3, 4 little boxes. So 4 little boxes. Each little box is worth 0.04 seconds. So that is going to equal 0.16. So that is for this EKG complex, it is taking about 0.16 seconds of time for the electrical complex or conduction to go from the beginning of the SA node to the beginning, or from SA node till it's being released from the AB node for that atrial contraction, and then up until the ventricles are ready to contract. A normal PR interval, normal, equals 0.12 to 0.20. So a normal PR interval is 0.12 to 0.20. So about 3 to 5 small boxes is 3 to 5 small blocks between 3 and 5 small blocks is a normal PR interval. If it was taking longer than 0.20, What would that mean? What's happening? Well, it means that that there is some holdup and that the electricity isn't flowing as quickly as it should from the SA node and then leaving the AB node. So there is a block somewhere in there. In that pathway, there's something in that pathway that's keeping it from going as fast through as it should. So let's look at the next piece. So that is going to be your PR interval. Beginning of the P wave to the beginning of QRS. How many little tiny squares do you have? Normal, 0.12 to 0.20. Again, these are numbers you have to memorize. 0.12 to 0.20 is your normal PR interval. All right, QRS. Let's look at your QRS complex. So remember, the QRS complex represents ventricular contraction. So the beginning, we're going to measure from the beginning of the QRS complex to the end of the QRS complex, from when it leaves the isoelectric line to when it returns to the isoelectric line. This amount of time represents that ventricular depolarization or contraction. Normal duration is going to be normal equals less than 0.12. So less than 0.12, which is 3 small blocks, 3 small boxes. So you're going to measure from the beginning of the QRS complex to the end of the QRS, from the beginning of the Q to the end of the S. So this particular one here looks like it takes up 2 small boxes. So that would be 0.08. So that's how we read the QRS complex. And again, it's going to be the same thing. If it's longer than that, then it means that there is something blocking it or keeping it from getting all the way through in an appropriate amount of time. So last up, we have our QT interval. So the QT interval is going to go from the beginning of the Q wave to the end of the T wave. So this is going to represent the total amount of time it takes for the ventricle to contract and then return to its normal relaxed state. The QT interval we do always measure, but I will tell you a lot of times what it's being used for as far as that QT interval has to do with medication management. So we're not going to talk a whole lot about what is happening, what does it mean if your QT interval is longer than what you want it to be, unless it's medication specific. So it's going to be that total time. Normal for a QT interval is usually around, it's usually around 0.36 to 0.40, 0.3, 0.32 to 0.40. About 8 to 10 blocks is a normal for that. All right. So so we've talked about what is it about making sure there's a P wave for every QRS, right? There should be a P wave, QRS, T wave for every complex. And this is when we are determining what makes it normal sinus rhythm. And remember, this whole presentation is about what's normal. So making it normal sinus rhythm. All these complexes have all the pieces we want them to have. So like if we're looking at this strip, it does. Every single one of these complexes has a P wave, a QRS complex, and a T wave. Next up are the PR interval and QRS complexes within normal limits. So that's going to be that PR interval will measure, the QRS interval will measure. Remember, normal PR interval, 0.112 to 0.20. QRS is going to be less than 0.12. And as I said, we'll measure the QT interval, but that's not going to be part of what's determining if it's normal sinus rhythm. So these are going to be the more important parts there where we're determining if it is normal sinus rhythm. Next up, is it regular? Does it march out? So regular means that it is the same amount of time between beats. That these spaces here are all the same. Okay, so there's two ways that you can determine that. I do not have calipers at home, but I'm going to show you with a pencil. So you can buy calipers. Calipers are like they're little metal guys that separate out, and you can use them to measure if it's regular. You can also, so you can buy calipers. There are digital calipers that can be used as well. I'm just going to pull up a picture of calipers real quick. So here's what calipers look like. So what you can do with them, let me annotate again, is when you're comparing them to an EKG, you can put these little points right on the tips of the QRS complexes. Okay, so after you measure out one QRS complex, then you can kind of march it out to make sure that they all measure the same distance from QRS complex to QRS complex. So that's how you're going to determine if it's regular. So is it regular? As I said, are these spaces the same? You could count the amount of boxes between them too, but it's easier to use calipers or paper. Lastly is, what is the rate? So we want a normal rate of 60 to 100 beats a minute. So how do we look at this strip and determine what the rate is? So remember, we talked about that every 5 boxes, 1, 2, 3, 4, 5, represents 1 second. So 1 second here. So when you're looking at your EKG paper, a lot of them have, let me erase that, have these little tick marks down at the bottom. There will be these little tick marks down at the bottom. We've got 3 here. So these tick marks represent, and it is different with different strips, okay? Different rhythm strips. Some of them have 3-second tick marks, some have 1-second tick marks, some have 6-second tick marks. So you need to confirm how far apart those lines are. So if you look at it, if it's a 3-second tick mark, a lot of them, that's what it has. There should be 3 seconds from here to here. So it should be 15 large boxes. If you measure them out, it should be 15 large boxes. 5, 1, 2, 3, 4, 5, 2 seconds. 1, 2, 3, 4, 5, 3 seconds. So you need to measure and make sure that your tick marks are what you think they are, because you may just only have 1-second tick marks. So using the tick marks, how we determine rate is we want 6 seconds of time. So we want a 6-second strip to go off of so that we can multiply. So for this one, we've got these tick marks at the bottom. We've got 3 seconds here, 3 seconds here. It's making our 6-second strip. So what we'll do is we'll count our QRS complexes. Remember, your QRS complexes are the ones that represent ventricular contraction, which represents perfusion. So that's what we're going to check. We're going to count. So up here at the top, we've got these arrows are pointing to these QRS complexes. So in this one, we've got 1, 2, 3, 4, 5, 6, 7, 8 QRS complexes in a 6-second strip. So what we will do is multiply our number of complexes in a 6-second strip by 10, and that will give us our rate. So in this case, as it says here, 8 complexes in 6 seconds approximates to 80 beats per minute. So that is one way that we can count the rate. Another way, there are other ways that we can do it. That is the easiest. If you have tick marks at the bottom of your paper, that's the easiest thing. You can also write your own tick marks if there aren't any. You could count out those boxes just like I did down here. Just like I did down here, and count out your boxes to get to where you need it to be. The other things you can do, you can count the number of large boxes between QRS complexes and divide by 300. These methods are not as accurate, I will tell you. So I'm just getting my calculator out so I can do it along with you. Okay, easier said than done. Okay, so here we've got 1, 2, 3, almost 4. Almost like right here would have been 4. So almost 4 boxes. So I'm going to go ahead and do 300 divided by 4 equals 75. So that's pretty close to our 80 that we got. So large boxes divided by 300. The other thing you can do is count out the small boxes. So for instance, here we've got, and remember we can count by 5. So we've got 5, 10, 15, 16, 17, 18, 19, 20, well, 5, 10, 15, we had like 19 because we were pretty close. So and then you can divide that by 1,500. So 1,500 divided by 19 equals 78, well, rounds up to 79. So even more accurate. So you can do that as well. If you have a regular rate, then you can do that as well. And so that's 300 divided by large boxes. And then, or 1,500 divided by the number of small boxes. Between, and that's both of those are going to be between QRS complexes. Okay, so that is the other ways that you can measure rate. Typically, the easiest thing, what we're going to do is we're going to want a 6-second strip, and we're going to go off these tick marks down here, count our QRS complexes in a 6-second strip, and multiply by 10. But I did want to give you other options also in case you do not have tick marks. So at this point, I'm going to erase all this stuff. So at this point, if you have not already done so, please print out, push pause, print out the rhythm strip practice with PowerPoints that I have uploaded for you. And we're going to do some practice reading some strips. And go through those together. And so we're going to do that along with the printout you have. So you'll need to have that printed off and ready for you to practice. And I just want to reiterate, so when we're looking, and we'll look at these practice strips, but when we're looking at what makes it normal sinus rhythm, does it have all the parts of the complex? Are things that we've measured out, PR interval and QRS complex, within normal limits? Is it regular? And is the rate between 60 and 100? And that's how we're going to determine if it's normal sinus rhythm. Okay, so if you haven't already done so, please go ahead and pause this and work this out on your own to determine if it's normal sinus rhythm. So please go through those steps on your own, determine if it's normal sinus rhythm, and then restart it, because I'm getting ready to go over it myself. Okay, so if you are ready, let's go ahead and look at it. So first question, is there a QRS for every P wave and a P wave for every QRS? And the answer is yes. We have, in every complex here, has a P wave and a QRS present. So that is a yes. So next question, are the PR intervals and QRS complexes within normal limits? So let's look at that. So let's, right here. Oh, I wrote a R. That's okay. I'm gonna just put P in front of it. PR, Q. Wow, I'm really bad at drawing Q's with this. QRS. Okay. So let's look at counting out our P wave. I like to choose whichever P, you don't have to use a specific one. You can use any one of these complexes. I like to choose one that starts right on a line. So for this one, we're going to start, I'm going to use this one right here, because it looks like this P wave leaves the isoelectric line right here on this line. So that's going to make it easier for me. So we're going to measure from the beginning of the PR interval to the beginning of the QRS complex, which is going to be right here. And then we're going to measure that. And sometimes we can look at other ones too. We've got this one starts on a line. And this one is right here. This one starts on a line. This one is a good one. So when we're looking at that, so now I wish I could zoom in. Maybe I can, but I don't know how. So we're going to count the tiny squares between them. So here we've got 1, 2, 3 tiny squares, maybe 3.5 tiny squares. So we're going to say that that PR interval is about 0.14. So about 3.5 tiny squares. And I'm only going off halves. I'm not going to go anything more than halves. They're just too small to determine. Other than that, that said, I know the question that you're asking is, well, I only got 3 squares. I had like a little over 3.5, and I thought it was closer to 4 squares. There is going to be a little bit of leeway as far as when people read it, they may have like 1 box of give or take. That said, for your testing purposes, I promise what we give you is going to be clear for you to be able to measure. Secondly, as far as that goes, and being able to measure, it'll be clear for you. The other thing is that you do have the ability on ExamSoft to zoom in so that you can see it a lot more clearly than what I can zoom this in as well. So next up, we've got our QRS complex. And again, I like to measure it based off of a line where it's starting on. So it looks like this one here, let's see. Let me erase what I've got on here so we don't get confused. Okay. So now we're going to measure from the beginning of the Q wave to the end of the QRS complex. And really, I don't see one that's on a line exactly how I want it to be. Maybe this one, So it's going to start right here and goes to here. So we've got 1, 2, 3 small blocks between. So 0. Let's see. I don't know. Let's go off this one. 0. Yeah, it's about 2.5 blocks that is what we've got here. So at the beginning of this QRS, I wish I could zoom in for you guys. It is hard to see when you can't get really close to it. So, but you guys can probably look closer on your paper. But about 2.5 blocks. So 0.2.5 blocks. So 0.10. And what was normal for those? Do you guys remember? Normal for a PR, 0.12 to 0.20. So this is within normal limits. It's in that range. This is going to be less than 0.12 is what is normal. So this is also within normal limits. So we do have a normal there. The other thing is there is a ton, I'm going to be giving you guys a ton of rhythm strip reading practice materials. So there's a lot of practice you can do, so do not stress out. This is just the first one that we worked together. So do not be stressed out if that was so scary and you did not know what to do with it. Lots of practicing to come. So those are within normal limits. That was question number 2. Next up, is it regular? So you could use calipers or use the paper method to determine if this is normal. I'm going to just hold my paper up to the screen and do it on here. And I will tell you what I get. And do the paper method and march it out. And it looks like, yes, it is normal. I wonder. I'll pause recording for just a second. Okay, so I do have this printed off. So I just want to show you what I mean about the paper method of determining if it's regular. So what I'll do is, it's hard to do this, okay, is hold a piece of paper up to my EKG so that I can see the tops of the QRS complex. I'm then going to use my pencil. I'll show you in a second after I do it. Okay, so I'm going to put lines on my paper. It's still going off a disc. Okay, so I'm going to put lines on my paper underneath those QRS complexes. So then what I'll do is I'll run it down the strip. See, they line up. To see if they line up. See that? Line up. So that is that paper method of determining if it's regular. So hopefully that helped. So the answer is yes, this is regular. And lastly is the rate between 60 and 100. So we do not have tick marks on here. So we can either, we're going to go with, really the easiest way, and I would like you to stick with, is doing the, I just wanted to give you extra methods where you could check yourself. Also, it may be a way like, I think this is what it is, but using the dividing by the 300 and the 1500. But the getting the 3-second tick marks is going to be important. So we don't have 3-second tick marks on this strip, so we'll have to count them out. So we'll start from here. We've got 1, 2, 3, 4, 5 is 1 second. 1, 2, 3, 4, 5 is 2 seconds. 1, 2, 3, 4, 5. There's 3 seconds. 1, 2, 3, 4, 5. 1 second. 2, 3, 4, 5. 2 seconds. 1, 2, 3, 4, 5. So this is a 6-second strip. So we will count our QS complexes. We've got 1, 2, 3, 4, 5, 6, 7, 8, making our rate. Our rate is 80. Okay, so that is your first rhythm strip. So our answer was yes to all 4 questions. So this is normal sinus rhythm. All right, let's try another. This is number 2 on your rhythm strip practice. So, first question. Are all parts present? Yes. So this looks different, doesn't it? It doesn't look exactly like you want it to. And that's okay, because nobody is the same and their anatomy is different. And so their rhythm strips are going to look a little bit different. But what are we looking for? P wave, QRS complex, P wave, QRS complex, P wave, QRS complex. We got that. We got all those pieces that we need. So it does have a P wave for every QRS and QRS for every P wave. Next up, we're going to measure the PR interval and the QRS complex. So we are going to right up here, PR interval, QRS. All right, so we're going to start measuring our P wave from the beginning, our PR interval from the beginning of the P wave. Okay, so I'm gonna start with this one. It leaves that isoelectric line. Oh, writing wasn't very good. Anyways. I'm gonna start right on this line here. This line. Okay, and then we're gonna start. It's gonna end over here where it leaves again for the QRS complex. So here it's basically from one large line to the next large line. So our PR interval is going to be 0.2, 0. Remember, normal was 0.12 to 0.20, so we're good. We're within normal limits. QRS complex, we'll just start right there. And we are going to go from there where it begins to here. The next line. So that is going to be 1, 2, 3. So about 0.12. 1, 2, 3. Yep. 0.12. Which remember it should be 0.12 or less. So we're good. So let me go back to that. I did tell you that it was less than 0.12, but it's 0.12 or less. Less than or equal to. Less than or equal to 0.12. 0.12 is still normal. So 3 boxes or less. So those things are normal. Next up is it regular? If we march it out using the paper method or calipers, is it regular? The answer is yes. And then the last piece is the rate. So this one, look at it here. We got these 3-second tick marks. We don't need to do any counting. We got a 6-second strip here. So we just need to count our QRS complexes that are within it. 1, 2, 3, 4, 5, 6 QRS complexes give us a rate of 60. So we answered yes to all of our questions. So we have here normal sinus rhythm. Even don't let it throw you off just because it looks different than the others. Okay. Remember, if you got a little bit different than I did, you got 1 box more, 1 box less. Remember, as I said, it is going to, there's going to be about a box discrepancy sometimes between when you're reading it, and that's okay. It will be clear on the test. All right, let's look at another one. All right, we got another one to practice here. So do you remember me talking earlier in this presentation about looking at two different leads? So here we've got one strip, one lead, and we've got one lead down here. So does it matter which one you read? No, it doesn't. You should get the same results. I read the one that's easier to look at. So I'm going to look at this top one because it's going to be a little bit easier for me to see the answers on. So let's look at each piece. First of all, does every complex, every QRS have a P wave, every P wave have a QRS? We're looking at all our complexes. They all have all the pieces they need. So it is normal. If you haven't worked this on your own, please pause it and work it on your own. Just listening to me work it out is not going to be helpful for you. Pause it, do it on your own, and then review and see how it compared. So next up, PR and QRS complex P intervals. I did that again. P, Q, R, S. Okay. Our P, we're going to start at the beginning of our P wave. Let's start here. Like this. Starts right there to the beginning of the QRS complex here. So we've got 1, 2, 3 boxes. Let's see. 1, 2, 3. Yep, 3. Maybe 3.5. About 3 boxes. 0.12. Normal was 0.12 to 0.20. We are good. QRS. We've got, I'm going to go with this one here. Here, let's see, we've got 1. Gosh, these dots are hard to see. 2, maybe 2.5. Yeah, I think about 2.5 boxes here. Look at this one. 1, 2. It was right in the middle of those. So it'll be 1, 2, 2.5. So, yep. So our QRS 2.5 boxes going to be 0.10. Is that less than or equal to 0.12? Yes, it is. So we're good there. Okay. Normally, I have these projected on the big screen. It's a lot easier to see. So let's see. Let me clear those drawings. So the answer to that question was yes. Next up, is it regular? Does it march out using calipers for the paper method? It does march out, so that is regular. The last thing is the rate. So we have, here's a 3-second tick mark. Here's a 3-second tick mark. This is going to be a 3-second tick mark, but we'll count it out just to be sure so we don't see. So we got 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. Oops. 1, 2, 3. Let's see. But that's okay because we got 2 more over here. 4, 5. So this whole thing together is 6 seconds. I hope that made sense to you guys. So this was 2 blocks short of being 3 seconds, but we've got 2 more blocks on this side over here. So the whole thing is going to be a 6-second strip. So let's count our QRSs. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 QRSs in there. So our rate is 100. 60 to 100 is normal. It's on the tippy top of normal, but it is still normal, just like 60 is also still normal. So what we've got here is a normal sinus rhythm strip. as I said, you've got lots of practice to do. You can work on the practice strips. We are going to have a big in-class activity where we will practice, and you can sit with me and Miss Stoig one-on-one, or one of us, somebody, and sit with us one-on-one to review these and look at the strips and see what you're doing or what you're doing wrong. I will tell you, it is a practice thing. The more you practice it, the more you'll get comfortable doing it. I know this is something that just, I know seems so foreign to you guys when you first start learning it. Practice. Every week at clinical, look at the strips, look at the strips, look at the strips. They all look different because, as I said, anatomy is different. People's cardiac anatomy is the same as their other anatomy, right? So the rhythm strips are gonna not look like a perfect cookie cutter rhythm strip. It's just not that often that you even get somebody who has that perfect normal looking normal sinus rhythm. So practice. Review back over this PowerPoint, and if you need to, and just continue looking at it, continue practicing it, memorize all the numbers, make sure you understand the anatomy. And we've got one more on here. So let's look at this one. It looks pretty, doesn't it? So what's first? We've got, do all the complexes have all their pieces? Oh, I'm gonna have to change from my green pen on here. Let's change to red. But yeah, we do have all the complexes we have all of their pieces. Next up, the PR interval. So, and the QRS complex, PR, QRS. Remember, pause this and work it out on your own. We've got beginning of the PR. We've got the beginning of the QRS down here. So that's going to be 1, 2, 3, 4 blocks. So we've got 0.16. QRS, is that normal? 0.12 to 0.20, 12 to 20, 16's in the middle. Good. QRS complex. We're gonna take this one to here. So we've got 1, 2 boxes. It's the same over here. Got 1, 2 boxes. So our QRS is going to be 0.08. Normal is less than or equal to 0.12, so that is good to go. That is a yes. So that is still normal. Next up, does it march out? It does march out, so it is regular. Lastly, our rate. What is the rate? Doesn't look like those other strips did it? But we're still going to count out to make sure that we're correct. So we've got 1, 2, 3, 4, 5, 1 second. 1, 2, 3, 4, 2 seconds. 1, 2, 3, 4, 3 seconds. 1, 2, 3, 4, 4 seconds. 2, 5 seconds. 1, 2, 3, 4, 5. We've got a 6-second strip. So our 6-second strip, let's count our QRSs. 1, 2, 3. Our rate is 30. Is that normal? No. So we had all our other pieces. So it was sinus, bradycardia. So this is our first abnormal when we looked at it and just looked at one thing being abnormal, and that's the rate. So on your next presentation, that is what we're going to be reviewing, is we're going to start looking at abnormalities and arrhythmias and what to do, what's your patient going to look like, what's going to cause them, and what we're going to do about them. So Before you go into that next presentation about arrhythmias and looking at abnormals, make sure you have a good grasp of what is normal. Because if you understand normal, then it's a lot easier to understand abnormal. Just like I bet when we pulled this one up, you could tell it looked a lot slower than the other strips did. So the better you understand abnormal or understand normal, the better you're going to understand abnormal. We'll continue building off this. As I said, you'll have the learning activity and lots of resources. Keep practicing, watch this video over and over and over, fast forward, rewind to the parts you need to. Practice, practice, practice. I cannot reiterate that enough. It's going to be a lot of memorization, but you've got this. Let me know if you have any questions. You can post to the forum or send me an email.